In addition to managing over 800 security officers and support staff, George Economas is responsible for planning and implementing new technologies and the development and deployment strategies to combat criminal activity in and around Johns Hopkins Hospital Systems institutions. He is also currently a member of multiple committees and professional organizations, including the Emergency Management Committee, the Health, Safety, and the Environment Committee, and the Risk Assessment Team. Now I will pass it over to George.
So good afternoon, everyone. Thank you for joining my session. This is a first for me, so I'm usually in front of a live audience, so sitting here looking at my computer screen is a little bit different for me. So bear with me if I kind of stumble a little bit in the beginning. Today, this afternoon, what we're going to talk about is the incident that occurred at Johns Hopkins Hospital on September 16, 2010. I'm going to give you a quick overview of our campus. I'm going to talk about the folks that were here that day. I'm going to talk about some of the things that we did prior to that event. We'll go through the event, and then we'll talk about the after-action assessment and some of the things that we've done since, and then we can open it up for questions and answers. So with that, can everybody see the screen? Are we good with that, Jessica?
Yes, we are. You are all set to go.
Okay, great. Okay, so the campus overview. Johns Hopkins Hospital is located in Baltimore, Maryland, and on the East Baltimore campus, the organizations that are here are the Johns Hopkins Hospital, Johns Hopkins University Schools of Medicine, Nursing and Public Health, and the Kennedy Krieger Institute. Our campus is in northeast Baltimore, and it consists of 6 north-southbound, north-south, and 8 east-west blocks. It's a large campus. It's an urban environment with many major thoroughfares crossing through our campus. On any given day, and this has changed since 2010, but on any given day at that time, we had about approximately 47,500 people on campus, 30,000 plus employees, 6,500 students, 950 inpatients, and approximately 10,000 visitors a day. That has since increased over the last few years. So prior to the event occurring here on September 16, 2010, corporate security got together after the Virginia Tech shootings. The leadership of corporate security got together and talked about, were we prepared should something similar occur on our campus or within our hospital. So what did we do? We assessed our vulnerabilities. We met with the police departments to discuss our strategies and needs in the event something occurred. We implemented the Johns Hopkins Emergency Alert System, which was a homegrown system that we had folks from our School of Engineering help build. Then we coordinated response with our emergency management team. We created some policies, and then we started training for all security supervisors. And finally, what we did was we obtained electronic copies of all of our floor plans and basically set up go bags in the event that we had a situation occur on campus. When I talk about the Johns Hopkins Emergency Alert System, this was the way that we would communicate an impeding disaster or imminent harm to persons and property. It was, like I said, it was a homegrown system. It was a text message system, and you had to subscribe. The numbers that you see here were what we had. The number of folks who subscribed to the service after the event in September of 2010. Prior to that, we had approximately 4,000 to 5,000 self-subscribed members. So we're going to get into the event. Okay, so the original call came in at 11:10 a.m. To the Johns Hopkins Communications Center. There were multiple calls that actually went out from the floor, stating that there was a shot fired, there were shots fired, and a doctor had been struck. So initially, the communication center immediately got on the air and broadcast to all available units that there's shots fired on Nelson 8. Responding individuals went up to the floor per training, and our training was not to confront, but to secure and not allow movement of a shooter in the event that it's an active shooter. So here's a picture of Nelson 8, 8th floor. The room that this occurred in was 873. And what happened is that we had a patient son, 50-year-old male, who was the primary caregiver of his mother, was not happy with the outcome of a very difficult and high-risk surgery. He was speaking with his mother's doctor when he pulled out a handgun. He says, "Mom's not going to be happy with this, and neither am I," with the prognosis, and then he shot the doc. He immediately went into Nelson 873. There was a sitter in the room. She immediately left the room, closed the door behind her, and then the charge nurse of the unit actually took a crash cart and placed it in front of the door in the event that the shooter would try to exit. So what I'm showing you now is the Baltimore City Police response as this came out. Okay, so this call comes out, and you can see this is the top of the circle where I just showed that building, and I'll show you this again. So here again, where the arrow is circling here, this is the top of the circle, and then we're looking at 873. So one of the things is that, and the reason why I bring this up, and I find it so critical, is when we were doing our debrief, what we did is we allowed first responders to come right into the field of fire. In the event that this individual had a long gun and was aiming to harm as many people as possible, we allowed our first responders to come right into that field of fire. So it was something that we had to consider as we started doing our after action assessment. So command post areas, one of the things that we got to be prepared for when events like this occur is multiple agencies setting up multiple command posts. So we had Baltimore City Police and their mobile command come in. We had Baltimore City Fire Department and their mobile command come in. We had the Baltimore City Office of Emergency Management set up a command center as well. So we had those three command centers. We had a strategic command, a tactical command center up on the 8th floor. And then we also had our security communications command center. So all of these command centers need to be staffed. And you have to establish communications between them. And again, we'll discuss that a little bit further in the presentation. So here's the timeline for what occurred that morning. So again, at 11:10 a.m., multiple calls were received by the Security Communications Center that by staff members alerting us to shooting on Nelson 8. All available units were dispatched. The Assistant Director of Internal Security, External Operations Supervisor, External Security Lieutenant, off-duty police officers were all instructed to call the Communications Center. The Assistant Director informed me at the time I was the Director of Internal Security that a doctor had been shot on Nelson 8. Don Bidenback and myself arrived on scene at approximately 90 seconds after the initial call went out. The assistant director, who was a retired law enforcement and was authorized to carry a sidearm, did take his sidearm out and covered those who were working on the doctor on the floor in front of the room. I instructed. Sorry. So at that point, we instructed the security lieutenant to activate our active shooter plan, and was broadcast over the radio. I was speaking on the phone with our emergency manager, and I asked him to activate our emergency alert system, the Johns Hopkins emergency notification system. Baltimore City Police Department Eastern District arrived on Nelson 8 within 5 minutes of the initial call, and they took command of the scene. Again, 11:17, 11:18, so we're talking 6 to 7 minutes into the event is when the notification went out. We had facilities on the scene shutting down elevators and assisting with other pertinent information. Again, we had the notifying alert message sent at 11:27, and then we had the decision to relocate and find beds for our patients at 11:45 a.m. You cannot just evacuate an inpatient floor, as many of you know, and that had to be coordinated through our Office of Emergency Management, and it took us about 45 minutes to evacuate everybody that could be evacuated. So we did have a command center set up in the hospital incident command center was set up in the Smith room, which is within the Billings building here. And then again, at 1:40 p.m., Baltimore City Police were able to give the all clear after using some electronic gear to determine that the shooter had taken his own life. So we're going to get into the after action assessment. So one of the things, the first thing that we did was we determined that mandatory staff training in handling violent and aggressive patients and family members. One of the things that we did in doing the after action report and talking with staff was this individual had shown signs of escalating behavior over the previous days, and no one shared that information. They did not share that information with a receiving unit, Nelson 8, who received them from the surgical intensive care unit, and then staff on Nelson 8 did not alert security as they noticed that his behaviors were changing. So one of the things we had to institute the mandatory training for staff in handling aggressive patients. The priority to incorporate the family patient aggressive behavior in the medical record. This is so that staff, if again, there's no predictor for future behavior better than past behavior. So what we do is if an individual acts out in an aggressive or violent way, that's noted in the non-medical side of their electronic medical record, so that staff will see that and make them aware. Then there's consideration to create some positions that would help with training and aggressive behavior management. So the assessment of threats, we looked at who and how often there are workplace issues. One of the things that we learned we had immediately had town meetings after the event the next day, because we wanted to address everyone's concerns. We wanted to make sure that everybody was safe and that everyone felt safe. So one of the things that we learned was it was not so much that people were concerned about this type of event. It was the daily abuse that they took, while providing care for patients. The verbal abuse, spitting, biting, kicking, those types of things. So we had to take that into consideration as we started moving forward. We met with law enforcement to develop mutual understanding of priorities. Again, when Baltimore City Police arrived on the floor, they wanted to evacuate immediately, and you can't do that in a hospital, and the police need to understand that. We had to develop a plan of action or response in regards to the first responders' needs, i.e. safe routes. Don't allow them to enter into the field of fire, and how to redirect incoming phone calls to the affected unit. So one of the things that we also learned was you were going to be inundated with phone calls. People are going to be calling to find out how their loved ones are. People are going to be calling to find out how staff is doing. We're going to have media calls. So and we were completely unprepared for the amount of phone calls that came in that day. And then we need to formalize a general policy and procedure on emergency management, safety, and security in regards to how to manage all of this. So the training the staff, and then we went into additional training for staff and include law enforcement and fire department personnel in those trainings. So we also recognize the need for multiple communication networks. Again, the initial emergency alert followed by authoritative source who will send out routine updates to staff. This is something that we found rumors will fly, and they did. And social media is actually so fast And what you need to do is you need to get on top of that and stay on top of that, so that the information that you want out as the organization gets out there and isn't drowned out by all the rumors and innuendo that's gonna be occurring. Again, expect the erroneous information from social networking. And we do talk about that within our orientations with staff it's um, frowned upon to be on social networking while working, and especially during an emergency event. Um, Security communication centers. Again, the phone lines were overwhelmed with incoming calls, so much so that we couldn't make any outside calls. And then there's who decides what business operations to continue. The Nelson Tower is away from the emergency department, but because of the police response and the fire department response, our emergency department was unaccessible to any EMS traffic or any drive-up traffic. And then we got to talk about evacuation decisions. Who decides that? The police or healthcare? Again, once the police come on scene, they will take control, then it's about expectations and how we can work together as partners to get things done in the most safe and efficient way for our patients. The after action assessment also we talked about command posts and multiple staffing of radio communications of the in an academic medical center, do we set up a unified command? While this happened in the hospital, we had multiple university buildings that were not aware of what was going on. And we're going to talk a little bit more about that. And then we had the vehicle and pedestrian disruption for folks trying to move around campus. And of course, crime scene requirements, how long are we going to lose that floor? And then business continuity. So our post-event and staff counseling and campus-wide meetings to address what occurred. We did that immediately the day after the event, and met with staff over a 12-hour period. We had 4 sessions for staff, and every one of them was standing room only in an auditorium that holds more than 400 people. So the recommended strategies for aggressive patient management, we talked about security behavior contracts, which are now called security behavior agreements, the behavior flag and the electronic patient record, which has been instituted, education regarding recognizing and handling potentially dangerous behavior, that's ongoing. And then, our patient visitor handbook revisions to address aggressive and threatening behavior from the patients and or their visitors, visitor guidelines, to address the aggressive behavior and its ramifications, maintaining data on everything that we have come in that's aggressive in nature, and then of course emergency communications, which is the gist of this. So with that, I'd like to quickly discuss that one of the things that we found is that the emergency communication system that we had was inadequate, to say the least. We did not hit the audience that we needed to hit, and we did not within the hospital. And then our other audiences over at the university buildings were completely unaware of what was going on inside the hospital. The only thing that they knew is what they were picking up off of social media and from the news media, which is not how we want to communicate with our staff. And that brings me to us to our relationship with Alertus, and the things that we've done since to help our ability to notify and communicate with our customers, internal and external, whenever we have a major event occur on campus. So with that, I'd like to open it up to any questions.
All right, thank you, George. That was awesome. So now, everyone, if you have any questions for George, just submit them in the question box there. and he'll be able to get to your question and answer it to the best of his ability. I do have a couple coming in, so let me ask you, George. In the aftermath of the shooting at JAH, what was the most critical thing you learned about the emergency communication system that day?
So again, the thing that we learned was that we were not able to communicate with everyone when we needed to in a timely manner. So again, during events like this, and I think it's pretty obvious to everybody on the line that when things like this occur, the most crucial thing is communications, giving individuals, giving staff members, giving students, giving people that are in our facilities the ability to make informed decisions about their safety and what to do. And we were unable to do that. We thought that we had a system in place, but again, it was not adequate at all. And so that was the biggest lesson learned from that morning.
All right. Next question. Can you give examples of how you've taken advantage of the lessons learned, how they were implemented, and how they have performed?
Sure. So one of the first things that we did is we started to look at our building systems and how we can communicate through existing systems. One of the things that we found was a lot of our older buildings on campus had the old bell type system, fire alarm systems, and there was no overhead speaker systems whatsoever. So one of the things is we had to look for solutions towards that, and we went out to market, and we ended up partnering with Alertus on the beacons and getting those installed in a lot of our buildings that did not have any fire annunciation system or overhead paging. We also, our IT department had contracted with Alertus too for the computer-based banner system for emergency notifications. They use their system is used for network issues that may occur with critical medical systems, but we also have access to that now for emergency notifications. So this way we can access everyone's computer, with the few strokes of the keyboard. So these are just two of the things that we looked at. We also implemented the voice over with the alert beacons. Now that we can go over the fire annunciation system and do voice commands using the speaker system that was installed for the fire emergencies.
Okay. Next question here. Someone that may know you, George. I was working in the facilities department at the time of the incident. Do you have armed officers inside and outside of NCB? During the incident, firearms were only permitted in certain areas for law enforcement.
So at this time, none of our staff members are armed. We use Baltimore City Police in an off-duty capacity to provide our armed presence on campus. Just July of last year, 2019, the Maryland State Legislature passed a law that allowed Johns Hopkins University to stand up our own police department. That's in process. Once we do have that police department stood up, they will be able to patrol inside the hospital on a limited basis, but their main position, their main function will be outside and on our emergency department. But they will be our first responders. So that would be our armed presence.
Okay, perfect. Thanks for answering that, George. It looks like that's all the questions we have for you. So we, from everyone that joined us today, we really appreciate you coming on. Thank you for joining us and being here. If you have any questions or need additional information, you can reach out to any of the speakers or marketing@alertus.com. We'll be happy to assist you. If you're looking for more information on Alertus and our solutions, you can visit our website at www.alertus.com. If you're interested in upcoming webinars, you can visit our website at alertus.com/webinars to see the full schedule. Thank you again for joining today's virtual seminar, and we look forward to seeing you again soon. Thank you.